It's a 47-year-old male patient, 80 kilos and 108 centimeters in height, presenting in 1 year since typical angina after 2 flight of stairs, class 2 to 3, on medications aspirin, metoprolol, and statins. ECG since sinus rhythm with signs of LV hypertrophy. Creatine kinase T and T and are normal. HbA1c is 8 and creatinine is 2. Stress test, no ST abnormalities at 75 watt, and echo not performed.
Okay, so next. So you have a 47 male who is on 3 anti-anginal medication and coronary artery disease modifying lesions. So go next. So he's on aspirin, metoprolol, and statin, and he has an angina on the treadmill test, right? With no segment abnormality. Next, please. So there is no next in the scenario. Okay, so we'll not discuss the scenario. Let's say that we have the patient who is indicated for cath, because this patient is not indicated yet. Anyway, so which axis you prefer? Radial axis. And do you have an evidence? Okay, there is an evidence, and you need to have this evidence in your mind. Radial artery axis decrease the mortality and morbidity, evidence-based, even in ST segment elevation and myocardial infarction. So there is a huge evidence. So try your best with radial. Yes, there is a complication from radial. There is a risk for you, but you need to do it because it is decreasing the mortality if you choose the radial over the femoral. And it is learning curve. Whenever you do radial more and more, you get the expertise more and more. So go ahead. So you choose the radial. Now they are using the left and right as well. Both are great. Actually, left, it's just the same anatomy for like the femoral, and I usually prefer it. So go ahead. Fluoro, everyone had lead apron. Go ahead. Safety of your team members is really important. So now, okay. So you're going with the regular or J-tip wire. Yeah, okay, go ahead. So, yes. So what catheter you want to use? Tiger catheter, okay. But your diagnostic, you're planning for PCI? Okay, so you need to explorate the anatomy. Okay, that's great. 3.5? Which one? Tiger catheter? Or 4? 4.0, okay. صورة نتكلم فيديو يعني okay, so you're advancing, you have to coordinate, or you're coordinating with your assistant scrubbing nerves. Okay, that's great. Okay, so off fluoro. Okay, fluoro now. So you're giving injection. Okay. Since it's demo, we'll not speak about how to be gentle. You're going with the left. So you need to go to the LAO 20 or 30 for the RCA engagement. Okay. That's very nice. LAO, yeah, good. So fluoro now, great. So your eyes on the hemodynamics, ECG. And usually we need to be in collimation with the protection. All these measures as part of the interventionist job. Okay, pressure is okay, waveform is okay, now you have an injection. So what we can see here? Ostial RCA, great. So what will you next, how to identify the ostial RCA better? Yeah, caudal view, I agree with you. Caudal, so just LAU and go caudal view a little bit, like 15 or 20, it's okay. Like spider maybe, it's one of them, but don't go deep spider. That's great. Have a test here and check, or go Cine if you would like. Excellent. So, but we have not seen any dampening or ventricularization, which is somehow is a good idea. And your catheter size actually it's one. So go to the next level if you want. Thank you very much. Yeah. So you will change the view. You're in a spider view. Or epi? Epi straight, you mean, or caudal? Yeah, okay. Okay. And pressure, your eyes always in left main need to be in the pressure. Excellent. So if you have pay attention to the case, the creatinine was 2. So you need to be very gentle with the contrast. Okay, so now, Cine in this view, epicaudal. Can we go epicaudal, please? Yeah, go to like epicaudal 30. More. Okay, that's okay. Now you take a Cine. Excellent. So one cranial if you want. So what's the plan? Let's say just because of the time, sake of time, what would be your plan? Now you have a 47 years who have typical angina, assuming that he is on full anti-anginal medication, and now he has an ostial RCA with clear left system. Let's say that's clear system. There is nothing there. So what would you do?
Because the patient is symptomatic, I would consider PCI to the RC ostium.
Okay. So I agree personally with the PCI because we have to revascularize. So how would you approach him? What's the catheter you won't use? What's the procedural measures that you need to do?
Because it's RC ostial lesion, there's risk of pressure damping and with engagement of the guiding catheter.
Okay.
So therefore, I would consider sidewall JR catheter.
Okay. It treats the physician rather than the patient, but okay. It takes our anxiety down, but the patient is still having the problems anyway. But yeah, it's one of the things. So how would you treat it? This one. Let's say ideally. Okay. Great. Okay. What would be your first choice? IVUS, yes. So far, let's say IVUS, till the OCT improves the ostium part, okay? And based on the imaging, you would do the intervention, right? So, do you think this is calcified lesion from the image? Can we run the image? Is it okay to run the RCA image? The previous one, RCA. It's 2 images in the RCA. Yes, and the next one? Okay, so, no, the previous one. Go previous. Back. Yeah. Okay. That's the one. It's not showing here. Okay. It's showing there. There. Okay. Do you think, so typically you have an ostial RCA with post-stenotic aneurysmal dilatation. That's the most common cause of aneurysm, by the way, in the coronary. And it looks calcified, maybe. So we can see with the imaging. So go ahead. So choose the catheter that you want to use. Okay. So push the wire in and check. I hope we will have enough time for this. Go, because we discuss a lot. Okay. I hope so. Actually, it's for the discussion, exchanging the knowledge. You haven't tell us your name. I'm Leonard. 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 Okay. Nice to meet you anyway. Okay, go ahead, JR. Guide catheter JR. Yes. 4. JR4. Yes, this. Okay. You know, these catheters are just treating ourselves. Yeah, honestly. But if at the term of patient has having ischemia or whatever, or dampening, I've seen people working without hemodynamics. I've seen them, honestly. They're doing lift me and PCI without hemodynamics. And they're just chatting. Go ahead, go ahead. Oh, okay. Oh, okay. You follow with the catheter, go, 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 all the way, all the way. No, push the wire more and more. Now you're on the neck. Good. You have a potential to be a neurointerventionalist. Go ahead, go ahead. It's okay. The same principles, by the way. No, that's too much. Anyway, since it's Zemo, we need to be forgiving. Okay, go ahead. Yes. Okay. You're inside the LV, PVCs. Okay. LV. Okay. Yes. Okay. You need to clear your system. Yeah, go ahead, go ahead. Just to save the time, be careful with your patient. Give heparin. Yes. Yeah. Sedation. Okay. How much heparin you want to give? He's 80 kg. You haven't given anything. Okay, go. Yeah, okay. Okay, I'll deal with this. Go, take the wire back. Never, in my opinion, do this. Put the wire at the tip of the catheter. It's like a hook. It dissects everything. Okay, go ahead. So you have to connect your catheter to the pressure, then monitor the pressure and do whatever you want. If you're there, you can use the side, or let's say you use the three-way. Which wire you want to use? What is that? What workhorse you want? No, okay, good. Go ahead, go ahead. Okay. You're seeing? Okay. So basically, patient will go immediately to the dialysis after wire is out. So you're very liberal with the contrast in this patient. Okay. You might take your. Okay, good. Usually the support with JR is not that much. You have the privilege to choose the others, like Amblat's catheter, whatever. Since you're going to the ostial RCA, so you will do this. Okay. Okay. Easy. Okay. Yeah. torque is very helpful. It's very ostial. Are you okay with the view? Because you're in a caudal view. So the engagement from the beginning was tough. Okay, now everything will be changed. Check the fluoro now. Okay. So whenever there is something is not going very well, you recheck everything in the cath lab, even your assistant. Sometimes they're holding the wires, and you think you're torquing the wire very well, and by mistake they're holding by mistake, or it's wrapped on the manifold. Okay, go ahead. Okay. Now you torque, you go easy. Great. I like this. Go all the way safely to the distal. Are you in the fluoro? Yeah, you are. Go, go, go. You should move right and left. Now you're on a small side branch. Yeah. Waveform has changed. Anyway, go ahead. Okay, catheter support is really weak. Okay. That's okay. So tell me now what to do. Do you think with this tough wire engagement or wire crossing, the IVUS catheter will go, or you need to do something before, like pre-dilatation? Okay, go ahead. So you do pre-dilatation, then you use the IVUS catheter. No, just balloon. Balloon and... NC balloon, okay, 2.5. As far as you make the balloon shorter, the slipping in or out will be higher. Okay. Can you check where is your balloon? Okay, go all the way. Coming now, yes, go. Okay, so the balloon is inside, you have deeply engaged in the lesion, so you need to negotiate with your guide. Okay. Okay, can you test now? Okay, go ahead now. Yeah, and you can take it a little bit back if you want to cover the ostium, and go with the caudal views better. Yeah, iliocaudal. Okay, that's great. Fluoro. Okay. Okay, you're not covering the whole lesion. You need to come back and push the catheter over the balloon, so it to disengage a little bit. Yes. Now you're engaged. So it is difficult, especially with JR. Okay, you might give like first inflation and check. Take the catheter a bit back. How much you want to go with the pressure? You're using 2.5 NC balloon in a 4 plus. So it slipped inside. You can check. Okay, go 12 as. You just for you see the pressure is still the same because you're disengaged. If floor, please. Okay. How did the do test here? Okay, you see, you're not even engaged. Right? I mean, you're deep. You do not prepare the region. So what do you think now? What do you suggest? You take it a little bit? Yeah. Go down or you keep it? Deflate. Because all this is schema time. Yes. So you push the balloon, take the catheter back, balloon will go inside. So yeah, and take the whole unit all back. Yes. Now you can see you're almost at the ostium. And if you take it like 2-3 millimeter outside, better. That's why I prefer longer balloons, not, let's say, 15 or 20 or 18 balloon. Because there is a cost for that. Okay, go ahead now. You see now you're covering the ostium. You can go up now. So up to what limit you want to go? 40. You said 14. It's a smaller balloon and NC balloon and it goes all equal. So why not to go to 20, 26? High, you open the artery. But after the ballooning, you need to be careful with your wire. So go all the way. Okay. Can you choose another balloon? You will go with a bigger balloon. What do you think the size here? So your catheter is 5 French, right? Okay, 3.5. But honestly, you have to, or you will image, then you will check. That's the true answer. But let's say that we have done an image and there is a calcium. Which balloon you will start or which modality you want to do? Then osteal lesion and you have a severe calcification, severe lesion in the RCA. What will modality you prefer? What modalities you have in your hand? Okay, cutting balloon, I like this because it is written in the guidelines you need to do scoring for osteal lesions. Excellent. Number 2, which is one of the new modalities, you can use IVL, so shock wave. And you need to do some preparation to give the balloon space to go and to be very cautious with the ischemia time. So you will inflate, you will choose a 3.5, for example, balloon by 10, 12, whatever you have. Then you start to deliver the shocks until you have a good calcium fracture and you open the lesion. Then you can do that time take the what? The NC balloon to pre-dilate. Take it from me. Do your best, do your tough work as a lesion preparation, even if you don't post-dilate. If you choose the true size of stent, you will be relaxed and happy with the result. If the patient comes to you for elective angio after 5-6 years, you will see your stent still there without any ISR if patient has no other risk factors. So I think in no shorter times, just my advice, osteal lesion, it is one of the complex lesion. If you want to categorize the complexity, osteal lesions, bifurcations, and etc. But one of them, the osteal lesion. Osteal RCA, it's not easy. There is a complication that might happen, and you need to be careful about it, which is dissection to the aorta. And this is one of the things that you have to pay attention. Whenever the first shot you give the patient from the diagnostic, put your eyes on the cusp. on there is no staining, nothing, because sometimes you're tired, you're at the end of the case, you cannot see very well, and there is a staining. Was it there before or no? So put it in your mind. Um, just if you want to ask anything, yeah, let's discuss it. I know, guys, you know better than me, just because I'm here today. Yeah, the simulator.
So you were not happy with the JR catheter. Would you recommend?
Personally, I don't use side catheters at all. Sometimes, if they open it, I said no. Give me an catheters without side holes, because it is not treating the patient. It is not treating the patient. Maybe, I'm not very sure if the blood would come through the catheter for the side holes inside the artery, but I'm not really sure because we're delivering a lot of equipment and etc. So there is no much place for blood to go through. So I don't use it. The question I'm thinking, would I use Amplatz catheter? I would use it. The big issue with the Amplatz catheter is dissection. The treatment of dissection is stenting. I'm planning for stenting from the beginning. So, two devices if I want to use. Usually, the main issue with me is the PCI. If I use the Amplatz, or let's say dissecting catheters, like Amplatz catheters, like the guide extension. So whenever I use it, I already set my backup plan. There will be a stent. That's my own approach. So this patient already planned for stenting the ostial RCA. So I would have much support better. I would use the AL more, shorter one, to give me space for ostial. The issue with the Amplatz, because deeply engaged dive in the site, the RCA, so you will be afraid of ostial coverage. But Judkins, left or right, give you this opportunity. But I don't. If you're confident enough and you have learning curve with the Amplatz, you can do it and you go. But there is a question: how to confirm that, or how to make sure that you cover the ostium? What techniques you can use to make sure that you cover the ostium? Yeah. And now you do everything, and already done. Now you want to stent the ostium, left main or RCA, whatever. Give me one technique at least. Any technique. Just, the beauty of intervention, that you can come up with a new idea. Nobody has thought about it. What if you put another wire floating in the aorta? So you take a BMW or whatever wire, you put another wire and keep it in the aorta. Whatever happens with the back and forth pressure with the stent, you are sure enough that the catheter is not deeply engaged. Right? And they call it, there is a name for this. There is a name for this technique if you want to use it. Anyway, we're done. It's okay. Huh? لا we're done خلاص. Just we're chatting. So, have you ever heard about Sazuba or Zuba? Okay, you can. It's easy. You can Google it. So you put. If I pronounce it well, I'm not sure. I'm not good in. So, let's say this is the catheter. We can take the catheter out just to check, or any catheter you have. Any catheter, okay. So if there is a wire here, outside, and the wire inside the artery, if the wire is outside here, you are 100% sure the catheter is not engaging deeply. So you put your stent and you take the good view for you. Usually for ostial lesions, we go for RCA. You go a bit caudal. and you can go the REO as well. For left main, usually we go steep iliocranial. So you make sure that the ostial, you can see it, and you make sure the stent is a bit 1 or 2 millimeters outside for to cover the ostium. So let's say that you did this and you stent. What will be the next? You want to post dilate, right? And the important thing in optimization of the stent in ostial PCI is, yeah. Okay, you want to make sure the stent like this, my hand outside. So if this, we call it flaring the ostium. You do it with appropriate size balloon, and you take the balloon half and half, or you take it out. Usually we do it, sometimes you're in a rush, you do it with the same stent balloon. You take it like halfway, then you flare it. You want to see the outside part getting bigger. And you take there is a flare-up balloons, you can use it either way. Anyway, thank you very much. I appreciate. I hope we did very well.
Thank you.
Thanks.